Hello friends, today we are going to discuss the question which was asked in DRNB Critical Care exam in October 2023, that is damage control resuscitation. So damage control resuscitation is the strategic approach to the trauma patient who present in the extremes. So in this discussion, the pathophysiology of coagulopathy in trauma patient, theoretical and the practical aspect of DCR, and the revolution of damage control surgery incorporated with the DCR are discussed. So coagulopathy in trauma. Traditionally, the coagulopathy observed in trauma patient was thought to be resuscitation-associated coagulopathy, which is caused by consumption of coagulation factor, dilution of coagulation factor after massive infusion, hypothermia, and acidosis. An increasing incidence of coagulopathy was observed with increasing amount of intravenous fluid administered. The administration of large amount of the fluid and the blood product, exposure of the body, and the surgical intervention performed for resuscitation caused the hypothermia. The alcohol and drugs, which are the one of the causes of trauma incident, increases the heat loss from the trauma patient. So hypothermia is observed in about 60% of the patient who require emergency operative intervention. So it is associated with platelet dysfunction, reduced enzyme activities, and increased risk of bleeding and mortality of trauma patient. So inadequate tissue perfusion due to hemorrhagic shock results in anaerobic metabolism and the subsequent production of lactic acid, which causes metabolic acidosis. The high chloride content in the crystalloid solution, such as 0.9% normal saline, exacerbate the metabolic acidosis. So the activity of the most coagulation factor is depend on the blood pH. For example, the activity of factor 7A, 10A, and 5A decreases by over 90 to 70% respectively when blood pH decrease from 7.4 to 7. Now the next is acute traumatic coagulopathy. Recently, injury itself is reported to cause early coagulopathy, which is known as trauma-induced coagulopathy or acute traumatic coagulopathy. Acute traumatic coagulopathy is obvious early coagulopathy and occurs prior to significant dilution within 30 minutes of injury, and it affects the quarter of the patient with severe trauma. The patient with this coagulopathy have high mortality than those with normal clotting function. Although the pathophysiology of the acute traumatic coagulopathy is not well understood, it is thought to occur following injury and concomitant hypoperfusion. Then acute traumatic coagulopathy is affected primarily through activated protein C, which causes both anticoagulant effect and fibrinolytic effect by inhibiting plasminogen activator inhibitor. So the coagulopathy in trauma is one of the disseminated intravascular coagulation with fibrinolytic phenotype, which is characterized by the activation of coagulation pathways, insufficient coagulation mechanism, uh, and increased fibrinolysis. Now the damage control resuscitation. Management of coagulopathy in trauma patients. In severely injured patient, unless the lethal triad of hypothermia, acidosis, and coagulopathy is prevented, death is unavoidable. So damage control surgery is the resuscitation strategy that was devised to avoid this physiological disorder. It consists of three steps, like abbreviated surgery to control hemorrhage and contamination, resuscitation in the intensive care unit, and the planned reoperation and the definitive surgery. So, resuscitation strategy of damage control surgery focused on rapid reversal of acidosis and prevention of hypothermia through the first two steps. However, direct treatment of coagulopathy was not emphasized in damage control surgery. The coagulopathy observed in hemorrhagic patient was thought to be result of resuscitation, acidosis, and hypothermia. Thus, the aim of damage control surgery was to avoid the acidosis and hypothermia resulting from aggressive definitive surgery. So, the little attention was paid to the early derangement of the coagulation function caused by trauma itself. In contrast, damage control resuscitation directly address the trauma-induced coagulopathy immediately upon patient admission or in pre-hospital setting. So, damage control resuscitation consists of balanced resuscitation, hemostatic resuscitation, prevention of acidosis, hypothermia, and hypocalcemia. Now, regarding balanced resuscitation. So, aggressive fluid resuscitation was the initial fluid therapy recommended. However, this approach may contribute to increased blood loss and higher mortality. Increasing incidence had shown that aggressive crystalloid based uh, resuscitation strategies are associated with cardiac and pulmonary complication, gastrointestinal dysfunction, coagulation disturbances, and disorder of immunological and inflammatory mediator. So the administration of the large volume of the fluid result in imbalance of intracellular and extracellular osmolality that affects the cell volume. So the disturbance in the cell volume then disrupt the numerous regulatory mechanisms responsible for controlling the inflammatory cascade. For this reason, the alternative approach to the treatment of hemorrhagic patient was recently proposed and practiced. This approach was introduced as permissive hypotension, delayed resuscitation, and controlled resuscitation. The aim of this resuscitation strategy is not hypotension, but rather to balance the risk of decreased tissue perfusion with benefit from prevention of coagulopathy. So, in recent edition of ATLS, emphasize the concept of balanced resuscitation and the term aggressive resuscitation has been eliminated. So they advise to use the 2 liter of crystalloid resuscitation as starting point for all resuscitation that has modified to initiation of 1 liter of crystalloid infusion. Early use of blood product for patient in the shock is announced. So after dealing with the fluid loss, now next is hemostatic resuscitation. In 2007, Boatman and the Holcomb et al. Reported a survival benefit for high ratio plasma to red blood cell in patients who receive massive transfusion at Combat Support Hospital. A high plasma to RBC ratio was independently associated with improved survival, primarily by decreasing death from the hemorrhage. However, it remains controversial which ratio, that is 1:1 or 1:2, is beneficial when the ratio should be achieved. In the first 6 hours, the patient receiving ratio of less than 1:2 were 3 to 4 times more likely to die than patient receiving ratio of 1:1 or higher. They concluded that the transfusion with FFP and RBC ratio over 1 within the first 6 hours reduces the risk of death by 60% in patients with blunt hemorrhagic trauma. So, the most recent randomized trial to evaluate suitable ratio of plasma to RBC for patients with severe trauma and major bleeding was performed in pragmatic randomized optimal platelet and plasma ratio, that is proper study, in which platelet patients were randomized to receive either 1:1:1 or 1:1:2 ratio of plasma, platelet, and RBC. Although mortality was not significantly different between two groups, more patients in 1:1:1 group achieved hemostasis. Exsanguination, which was predominant cause of death within the first 24 hours, was significantly decreased in the high ratio group. Now the next is reward. Hypothermia should be managed in conjugation with the effort to correct trauma-induced coagulopathy. So it is essential to rewarm torso using passive rewarming methods such as insulating foil, blanket, the removal of the wet goods. So the initial fluid resuscitation should be carried out with warm infusion at fluid temperature of 40 degree to 42 degrees Celsius. Heated air inhalation, gastric body cavity lavage with warm fluid, and heat irradiation are widely performed, as well as standardized use of warming measure with rapid infusion. The temperature in the emergency room and the operating room should be raised at best to thermally neutral range. If the hypothermia persists or quickly relapses, despite this maximum rewarming effort, ongoing hemorrhage and unresolved tissue hypoperfusion and hypoxia should be suspected. Now, reversing of acidosis. Buffering of metabolic acidosis using drugs not only aggravate the intracellular acidosis but also does not reverse the coagulopathy. So, reversal of metabolic acidosis in trauma patient is better obtained through fluid and the blood resuscitation and vasopressor support with surgical control of the hemorrhage. So, shock should be reversed with end organ perfusion is restored. Because vital signs such as blood pressure and heart rate are not adequate to evaluate peripheral tissue perfusion, several endpoints of resuscitation are addressed. Base deficit and lactates are reliable indices with which to evaluate adequacy of resuscitation and endpoint perfusion. Not only the initial lactate value upon admission, but also lactate clearance from plasma within first few hours of resuscitation correlate with mortality of the trauma patient. Now regarding tranexamic acid, because hyperfibrinolysis was recognized to contribute to the acute coagulopathy and trauma, administration of antifibrinolytic agent had theoretical benefit. The clinical randomization of antifibrinolytic in significant hemorrhage, that is CRASH 2 study, large multicenter randomized control trial, investigated the effect of tranexamic acid on mortality and the blood product requirement in trauma patients with hemorrhagic shock. The study was undertaken in 274 hospitals in 40 countries. More than 20,000 adult trauma patients were randomized to receive either tranexamic acid or placebo within 8 hours of injury. All-cause mortality and risk of death due to bleeding were significantly decreased with administration of tranexamic acid. Maximum beneficial effects were achieved if it was given within the first 3 hours of injury. However, a recent study indicated that majority of severely injured patients who have fibrinolysis shutdown, therefore tranexamic acid have no effect. The greatest benefit of tranexamic acid may be in patients in whom increased clot lysis is shown to be present using thromboelastography. Now, fibrinogen component. Fibrinogen plays a central role in the coagulation process. It bridges activated platelet and works as a key substrate of thrombin to generate stable fibrin mesh. In patients with the blood loss, fibrinogen has been reported to decrease more rapidly under critically low concentration than the other coagulation factors. Thus, supplementation of fibrinogen is a measure that makes sense when treating coagulopathy of trauma patients. The effect of administration of fibrinogen concentrate on outcome was investigated by match pair analysis using German trauma registry. Although 30-day mortality was comparable, 6-hour mortality was significantly lower in patients receiving fibrinogen. The fibrinogen concentrate might have delayed the cause of death from early hemorrhagic collapse to late multiple organ failure. Now, prothrombin complex concentrate. Recently, the prothrombin complex concentrate derived from the human plasma and it contains the variable amount of factors like factor 2, 7, 9, and 10 is used to correct coagulopathy. Goal-directed coagulation management using thromboelastography was used to evaluate requirement of clotting factors. So the administration of fibrinogen concentrate alone or in combination with prothrombin complex concentrate resulted in significant improvement in fibrin polymerization and shorter clotting time. The Scott et al. Uses fibrinogen concentrate and prothrombin concentrate complex as first-line therapies for coagulopathy based on thromboelastography in study of 131 severely injured patients. Transfusion of fresh frozen plasma and cryoprecipitate was avoided in vast majority of these patients and outcome were better than the predicted. Now the next is about the transfusion of cryoprecipitate. In countries where administration of fibrinogen concentrate is not approved in trauma patients, Cryoprecipitate is the alternative treatment option as a source of fibrinogen. However, there are no reports suggesting a positive effect of cryoprecipitate administration on the survival of exsanguinating trauma patients. Although cryoprecipitate contain high concentration of fibrinogen, it is hampered by several relevant disadvantages in the term of its availability, allogenicity, and the need for blood type matching and time-consuming thought. Because the timing and indication for administration of cryoprecipitate were unclear in previous reported studies, a prospective randomized trial will be required to evaluate its benefit. Now about calcium. Calcium acts as important cofactor in coagulation cascade. Low level of ionized calcium at admission are associated with increased mortality and increased requirement for massive transfusion. So citrate, which is used as anticoagulant in the blood product component, chelates the calcium and exacerbate the hypocalcemia, particularly when used in FF. The faster the transfusion given, the faster is the reduction of calcium concentration occurs. So the ionized calcium concentration of less than 6.6 to zero point 0.7 would lead to coagulation defect. In addition, contraction of the heart and the systemic vascular resistance are diminished under decreased ionized calcium level. Because of its combined beneficial cardiovascular and coagulation effect, calcium concentration should be monitored periodically with every 10 units of transfusion, and it is recommended that concentration of at least 0.9 mmol be maintained. Now about massive transfusion protocol. Massive transfusion is typically defined as transfusion of 10 or more units of packed red blood cell within first 24 hours of injury. It is important for resuscitation staff to identify patients who might require massive transfusion early in the process of initial resuscitation. Following the prediction of massive transfusion, blood product should be delivered in quick and timely manner at high ratio of plasma, RBC, and platelet. To achieve this quick response, not only the resuscitation staff but also blood bank staff need to incorporate pre-implemented guidelines in the flow chart for massive transfusion protocol into their work. The protocol includes the patient selection for activation of MTP, description of the staff who should declare the activation, and the means by which resuscitation team and blood bank are informed of protocol activation. In blood bank, the pool packs of O negative RBC, type ABFFP, and platelet will be pre-packed for quick delivery. High ratio pack is continually delivered each time the blood is requested until protocol is deactivated. Type specific blood will be delivered as soon as the patient's type is determined. The MTP was implemented in 85% of trauma center in USA of 2010. The MTP is bundled with administration of calcium factor 7A and fibrinogen. The lab examination of coagulation function by thromboelastography is included as other standard blood lab test. The beneficial effect of implementation of MTP have been reported by several authors to be reduction in mortality and in use of blood product. Furthermore, the compliance with the protocol affects the patient outcome. Because it is complex to transfuse blood product in timely and safe manner, implementation of MTP is essential for institutions caring for severely injured trauma patients. Improved blood bank procedure, effective and efficient rewarming procedure, application of damage control technique, and aggressive correction of coagulopathy will contribute to survival benefit. It is important to activate MTP as quickly as possible. However, it is worth considering that massive transfusion, especially with administration of FFP, has adverse effects for subgroup of trauma patients. Inaba and colleague retrospectively investigate the incidence opportunity following plasma transfusion in patients who did not require massive transfusion. Although there is no improvement in survival with plasma transfusion, the overall rate of complication was significantly higher in patients receiving plasma product. Several scores such as trauma associated several severe hemorrhage. The scoring system developed by Loughlin assessment of the blood consumption, tranexamic bleeding severity score are proposed for prediction of the patient who require massive transfusion in early phase of resuscitation. Each score includes systolic blood pressure, heart rate on admission, and after initial resuscitation. The focused assessment with sonography for trauma, extremity and pelvic injury, sex, age, lab data are assessed to calculate their score. TBSS score was modified to predict the need for massive transfusion more quickly. The systolic blood pressure on arrival but after fluid resuscitation was used. The predictive value for the modified TBSS is still high and reported to be equivalent to that of the TASH score. Now regarding damage control resuscitation and damage control surgery. Although damage control surgery was popularized and resulted in reduced mortality, the abbreviated surgical technique and open abdomen management led to significant increase in subacute complications such as open abdomen, acute respiratory distress syndrome, intra-abdominal infection, and multi failure. Thank you, guys.